This is a new series that we are launching in terms of our shared service platform for urology as well as the radiology platform is concerned. We call it the Consona series. So today I'll focus on the entire segment of the Consona series, and Consona N8 is our mid to high end segment with most of all the features that you do do it in the routine cases, and along with the artificial intelligence. So it is powered by a technology, something known as zone sonography technology, which is a innovative technology in terms of how we see when the imaging is concerned. They have miniaturized the entire beamforming technology in a software driven approach. So coming out from the conventional line by line processing architecture, it is now moving to zone by zone architecture, which is 10 times more faster processing compared to the conventional machines. So it is a very giving a very smart design with a 21-inch display, and this is the entire console, how it looks like with a big touch screen with lot of customizing buttons all on the control panel. And this is our entire transducer family or the probe range, where it covers us with single crystal probes, with biplane probes, linear probes, as well as if you are doing 3D 4D imaging also, we are giving convex volume architecture probes. So as per the image this slide is concerned, it covers all the applications starting from urology, if you want to do routine abdomen, gynae, as well as the 3D 4D, as well as cardiovascular. So when we call smart anything which is related to smart, it comes with automation or AI. So we have a lot of smart tools in this to tackle your routine diagnosis and extra features. So these are some of the new techniques or new applications that we have launched with this ZST Plus. We have something called HD scope, which when we turn this on, it try to enhance any pathology, put it on any pathologies or nodules, it will try to enhance the resolution on that particular segment. Sometimes due to reverberation, due to patient fat, there is a lot of reverberation comes in the image in the near field as well as in there is a vessel. So we have something called dehaze. When we keep on increasing the dehaze, it will suppress the low intensity noise, and the vascular resolution, the noise will be more suppressed. We are offering shear wave elastography for liver, that is called the 2D shear wave elastography. That is one of the most useful tool if we are doing the liver for the fibrosis study, as well as the shear wave now we can use for the small parts for breast and thyroid, as well as we are offering it in the TVS probe, so you can use for prostate imaging as well. So similarly your normal strain elastography is also there along with the shear wave. Advanced studies, we have contrast ultrasound. So if we are very familiar, some people are very familiar with the contrast imaging, that is also there. That is with you can use it for routine GI cases, as well as we can do in prostate masses. So brief and the obstetric. So we have normal 3D 4D features for the obstetrics. And we have AI tool called Smart OV, which will give you the automatic biometry of the during your routine studies of the BPD and entire fetal biometry. This is the entire applications that is focused on our OB applications. That is something called Smart Scene 3D, which is a totally AI driven tool. And this is something called Smart Face. So if many doctors who are doing the 3D 4D imaging daily will understand lot of noises suddenly comes in front of the fetal face. So in one touch of a button, it will remove the occlusions in front of the face, just like this. So another thing that we have launched, that is a smart fetal heart rate, that when you are doing your fetal echo imaging, so continuously the machine can monitor the heart rate. We no need to go to the M mode and calculate. You just need to turn the FHR option and it will calculate the heart rate. And this is again for the routine gynec cases, like we can do autofollicular count even in the 2D probe, for the 2D TVS probe as well. No need to go for a 3D sweep. You go for a routine section of the ovary and it will give you all the follicular count in that particular segment. Another very useful tool that we have given, that is a smart bladder. So you take the routine like a pre-void section, you go to the smart bladder option, press one click of a button, you get all both the bladder volume automatically. This is another application that if you are doing for the pelvic flow study, that is we call smart pelvic. It is basically to evaluate for the pelvic floor dysfunction. It's a totally automation tool, like you take one sweep from the transperineally from the levator hiatus till the rectum, and all this sections with the levator and in the coronal section of the pelvic floor comes automatically. So these are some of the images that we have collected for concerning to the uro and prostate images, like for the shear wave elastography, contrast, as well as microvascular flow. So along with this, I just want to conclude my presentation and asked my team to for the product launch. So I will like to call upon doctors, Dr. Prashant Darak, Dr. Abhay Mahajan sir, Dr. Ramesh Malani sir, Dr. Ajay Oswal sir, Dr. Arun Chincholi sir, Dr. Ajay Ware sir, Dr. Iqbal Mane sir, Dr. Anirudh Kulkarni sir, and Dr. Mishri Kotkar sir to come up on the stage and just unveil the product.
Our next topic is imaging in renal trauma, for which I would like to call upon the stage our moderators, Dr. Devdutt Palnetkar, Dr. Abhay Kasliwal, Dr. Uma Shankar Kavlas. I would like to call upon the stage our speaker, Dr. Shahana Akram, to present upon imaging in renal trauma.
Good morning, everyone. I'll be presenting a brief talk on imaging in renal trauma. I'll start by giving a disclaimer that the images in this presentation have been taken from various sources of literature. First, let us start by looking at the symptoms which necessitate the performance of a renal trauma evaluation and the CT protocols that are necessary for the same. So, the clinical suspicion for renal injury in case of blunt trauma includes gross or microscopic hematuria along with a systolic blood pressure lower than 90 millimeters of mercury at presentation. And renal trauma protocol is also done in cases of any penetrating trauma of the abdomen, flank and lower chest. It consists of a non-contrast phase which is necessary to depict acute intraparenchymal hematomas that can become isoattenuating on contrast study. It can also help us to identify a pre-existing calculus. Next, we need to do a corticomedullary phase that helps us in evaluating vascular injuries, and a nephrogenic phase which helps us to evaluate the renal parenchymal injuries. Lastly, an excretory phase is also extremely important, performed at 5 to 7 minutes of delay to depict collecting system injuries. I shall begin by giving the classification given by the AAST for grading of renal injuries. Grade 1 injuries include a subcapsular hematoma or a contusion. Grade 2 injuries include lacerations less than 1 centimeter in depth or a perineal hematoma confined to the perinephric fascia. Grade 3 injuries include lacerations more than 1 centimeters in depth and vascular injury or active hemorrhage which is confined by the perinephric fascia. Grade 4 injuries include lacerations with pelvic involvement or a uretropelvic disruption. A segmental vein or artery injury, active bleeding which extends beyond the perinephric fascia, and segmental or complete infarct due to vessel thrombosis without the presence of an active bleed. Grade 5 injury includes a shattered kidney, a devascularized kidney with the presence of active bleeding, or main artery or vein laceration or hilar avulsion. Now coming to how do we identify renal trauma on imaging. The first set of images are axial and sagittal contrast enhanced images representing a renal contusion in the posterolateral right kidney as a focal hypoattenuating region with indistinct margins. We can see that it has a density greater than that of the bile in the gallbladder and also simple hepatic cyst fluid. The second image represents a laceration. There's an axial CECT image which demonstrates a laceration extending from the posterior aspect of the kidney to the periphery of a renal pyramid. Because it is less than 1 centimeter and does not extend to the calyceal system, it is classified as a grade 2 injury. Then we have a subcapsular hematoma. This is an axial CECT representing a subcapsular hematoma along the lateral aspect of the left kidney. The renal contour here is maintained and there is no perinephric hemorrhage consistent with a subcapsular hematoma with an intact capsule. This injury is consistent with AAST grade 1 injury. The next image is an axial CECT depicting a perirenal hematoma. Here we can see that the edges of the hematoma are ill-defined and do not exhibit any significant mass effect on the kidney. In contrast to a subcapsular hematoma, perirenal hematomas can be classified as either contained within the Gerota's fascia or extending beyond the Gerota's fascia. Here we can also see a coexisting laceration which is present. Next is a renal collecting system injury. These are axial CECT images in the nephrographic phase and in the delayed excretory phase, which shows extensive lacerations in the inferior pole of the left kidney. And a perinephric hematoma is also present along the posterior margin of the kidney. In the excretory phase, we can see leakage of contrast, which accumulates along the inferomedial aspect of the kidney. Any urinary collecting system injury is a feature of either AAST grade 4 or grade 5 injury. Coming to renal infarcts, this is an axial CECT image which demonstrates typical appearance of a segmental infarct as a wedge-shaped hypoattenuating area which spans the full thickness of the renal cortex with the apex at the hilum. A segmental renal infarct here is a feature of a AAST grade 4 injury. These are coronal and axial CECT images showing a complete renal infarction in a different patient. Here we can see abrupt left main renal artery occlusion is noted and a faintly enhancing vessel at the renal hilum represents an accessory renal artery. Complete renal infarction due to vessel thrombosis without the presence of an active bleed is classified as an AAST grade 4 injury. Now coming to vascular injuries, the first set of images represent arterial pseudoaneurysms. This is an axial CECT in the arterial and the nephrogenic phase demonstrating an arterial pseudoaneurysm. Here we can see a lobulated focus of contrast which is present in the anterior aspect of the interpolar region of the kidney, with attenuation similar to that of the aorta. Here, the focus of contrast in the later phases retains its rounded morphology, but here the attenuation has diminished, but it is still similar to the aorta. Then a pseudoaneurysm which is contained to the Gerota's fascia is again classified as a grade 4 injury. The second set of images demonstrate an active bleeding. Here an irregular focus of contrast is seen within the right kidney on the corticomedullary phase, which expands on the subsequent images. Additionally, we can also see presence of lacerations, perinephric hematomas and gas. Active bleeding which is confined to the Gerota's fascia is again a component of grade 4 injury. Coming to the shattered kidney, these are coronal images in the nephrographic and the delayed phase which demonstrates complete destruction of the interpolar region and the inferior pole of the right kidney, whereas the upper portion of the kidney appears to be more intact. In the second image, we can see extensive urinary extravasation within the regions of the destroyed renal tissue. Shattered kidney is often associated with either a vascular or a collecting system injury, and shattered kidney comes under grade 5 classification of AAST. Now coming to the role of USG, sonographic renal evaluation in trauma has a limited role because of overlying rib fractures or subcutaneous edema and patient immobility. Further, patient discomfort and diminished sensorium also contribute to limiting factors of the role of ultrasound in cases of trauma, and it is also operator dependent. But in some cases, we can see, like in this image, that the shattered kidney in a patient here, which on ultrasound is depicted as an irregular hypoechoic region, and the intact pyramids are characterized as hyperechoic regions adjacent to the cortex. Then in the next set of images labeled as C and D, here we can see a subcapsular hematoma, which on ultrasound is seen as a hypoechoic collection which is contained by the renal capsule and exerting a mass effect on the renal parenchyma. Now, coming to the question as to can MRI help in cases of renal trauma? Whereas MR imaging is not always available as an emergency procedure, and it also requires longer imaging time. Therefore, it only has an adjunctive role in patients in trauma where equivocal CT findings have been seen, but it can be used when evaluating stable patients who have a proven allergy to iodinated contrast media or in pregnant patients. But in general, it does not have a prominent role in imaging in trauma. These set of images represent a traumatic renal injury which has been identified on MR. In the image labeled as A, we can see a non-enhancing focus which is extending in the anterolateral left cortex into the renal hilum. It is compatible with a traumatic laceration. The second image is a coronal section which demonstrates a T2 hyperintense rim of perinephric fluid, which is concerning for a urinoma or a hematoma. Axial non-contrast images labeled as C and D demonstrate layering blood products and debris within a mildly distended urinary bladder. The findings here are overall compatible with AAST grade 3 or 4 renal injury. Here we can see subcapsular hematomas on MR imaging. These are axial T1 and T2 weighted images demonstrating a subcapsular hematoma with mixed signal characteristics on the T1 image and appearing predominantly hypointense on a T2 image. We can also see a curvilinear T1 hypointense and a T2 hypointense rim along the medial aspect of the hematoma, which reflects hemosiderin staining, which is consistent with a subacute time course. Now, a take-home message is when can we help the urologist to go in for an operation? The three absolute indications to take up the patient for surgery include life-threatening hemorrhage, a renal pedicle avulsion, which can include a uretropelvic avulsion, and an expanding retroperitoneal hematoma. Thank you.
Now I would like to call Dr. Sai Swaroop sir to have urology opinion on this topic.
Good afternoon, everyone. I would thank the Radiological and Aurangabad Urological Society for giving me this opportunity to speak on the topic imaging in renal trauma. So, the three things which I like to cover is what are the indications for imaging, what are the urologist expectations from imaging, and its importance in surgical management. According to the AUA Eurotrauma guidelines, these are the indications for imaging for a renal trauma. Patients with a penetrating trauma with a likelihood of renal injury who are hemodynamically stable, patients with a blunt trauma with a significant acceleration or deacceleration injury, all patients with blunt trauma having a gross hematuria, all patients with blunt trauma with microhematuria and hypotension, and all pediatric patients with a greater than 5 RBCs in urine routine examination. Now, which investigation, as my previous speaker has already told, that is the imaging of choice. There is a saying that one-shot IVP, which was earlier done for on-table, if there was earlier when there was no CT scan available, unstable patients who require an emergency exploration, a one-shot IVP with bolus intravenous injection would give an idea regarding the grade of renal injury, but nowadays this is not done. Does angiography have any role? That we will be seeing in the subsequent thing. Does CT scan, we all know that CT scan is the investigation of choice. Does CT scan have any major limitation? So I would like to discuss afterwards whether we can define a renal venous injury adequately on the CT scan. We being a urologist, we get images which are static. We don't have a dynamic imaging. For renal trauma, it is important that a dynamic imaging facility between a radiologist and urologist should be there, so that we can, as well as a radiologist, if he generally does not miss, if he miss is any contrast leak or anything, or any hematoma which is expanding on it, we can get it on a dynamic imaging. So what are the expectations from imaging which we expect a radiologist to comment in the report, because this we cannot predict on a static image, is whether there is a large perirenal hematoma that is more than 3.5 centimeter in adult, more than 2.2 centimeter in children, a vascular contrast extravasation, a medial renal laceration, more than 25% of renal parenchyma is devitalized, medial extravasation of urine during excretory phase, a urine extravasation and lack of contrast seen in the distal ureter during the excretory phase. So on this, we had a case with us in which a 19-year-old male had complaints of right flank pain, fever with chills, hematuria. Patient had a history of fall 1 week back. The vital parameters were normal. On abdominal examination, he had a right flank tenderness. On investigations wise, his hemoglobin was normal, his creatinine was marginally raised, that is 1.3. On the ultrasound, I don't have the images, but the ultrasound report said that it has a laceration of depth of 2 to 3 centimeters at mid-pole, right kidney with small parenchymal and perinephric hematoma. The important thing is we should not restrict ourselves only with the ultrasound report. It is mandatory that we get a CT scan and preferably a CT IVU. If we don't have a creatinine, I think one time a contrast can be given. If we can't get a creatinine in emergency because if the patient is critically ill, then a single contrast study of CT IVU can be done. So these are the CT images. Here we can see that there is a perirenal collection. This is the excretory phase which I have. There is a perirenal collection, and this you can see there is a contrast extravasation into the perirenal area. So these are the sagittal in which we can see that there is a contrast extravasation into the perirenal area. So this is basically a pelvic alveolar system injury, that is a grade 4 injury. For a urologist, grade 1 to 3, we tend to be conservative in terms of giving bed rest, IV antibiotics, monitoring the hemoglobin level. Two important things: whether there is an active bleeding, a PCS injury, keeps on our toes saying that we need to intervene somewhere. Now this grade 4 PCS injury, now we have in mind whether do we go directly for a nephrectomy or there are any certain new things or any, before doing a nephrectomy, are there certain other things? Yes, definitely there are certain things that we can go for a DJ stenting. So that in this patient the patient underwent a DJ stenting. Here we can see on RGP that there is an active contrast leak when we are doing a retrograde pyelography. So in this patient we did a DJ stenting, and post 1 month we did a CT scan. So not only CT imaging is done pre-trauma, it is if we intervene in terms of a minimally invasive technique like stenting or a PCN, it is important to get a post trauma CT. It is very important that we mention in the requisition that it is a post-trauma patient and what intervention has been done. So, and it is preferably that if the CT scan gets done at a center which already had a pre-CT done already, so that it helps for the radiologist to at least compare it or send the images with the patient to the radiologist so that he can have a look of the pre-CT, pre-intervention images and comment whether the collection or whether the findings which we need have been achieved or not. So in this case we can see that after 1 month we did a CT scan. Here the perirenal collection has decreased, it is very minimally streak and the stent is in C2. So this patient, after 15 to 20 days we removed this stent. We even did an ultrasound before removing the stent just to confirm that the perirenal collection has decreased or not. So in a gist, a patient with a blunt trauma can be managed with conservative, but a patient with a blunt trauma having a shock, he needs to undergo CT images if he is able, if the hemodynamic condition is little bit stable, we can get a CT scan if he is in the same institute and we can determine what grade of injury is done and whether we have to do any surgical exploration in terms of a surgery or an angioembolization. So these are the absolute indications for a renal exploration or a speedy angioembolization. Absolute indications are hemodynamic instability, a expanding of pulsatile renal hematoma, a suspected renal vascular pedicle avulsion, a UPJ avulsion. And relative indications are urinary extravasation, renal injury, arterial thrombosis and urinary extravasation from parenchymal injury. So angioablation will only help for if there is a vascular bleed. It will not help for a PCS injury. For PCS injury, either we do a DJ stenting, that is a double J stenting, or a PCN insertion to decrease the collection and then assess the patient whether he is improving or not. These are the EUA guidelines which strongly suggest that many blunt trauma patients can be managed non-operatively with close monitoring. Isolated grade 1 to 4 stab injury and a low velocity gunshot wound can be managed non-operatively. A selective angioembolization for active renal bleeding is an indication for if to avoid immediate surgical exploration. and insert a stent or a nephrostomy if there is a perirenal drainage in case of a persistent or symptomatic urine leak. The role of angioambulation is case selective. There are no certain specific indications that these has to be done. A stable patient in which if it is a grade 4 injury or a grade 5 injury, grade 4 which is a segmental bleed is there we can go for a selective angioambulation. A trial of single angioambulation can be given before going for a surgical option of a nephrectomy or a vascular reconstruction. Another, proceed with renal exploration in the presence of persistent hemodynamic instability, grade 5 vascular or penetrating injury, expanding or pulsatile perirenal hematoma. There is a weak recommendation for renal reconstruction if hemorrhage is controlled and there is a sufficient viable renal parenchyma. Also, there is a weak recommendation that follow up approximately 3 months. So there is no fixed protocol when to follow up, but a follow up imaging preferably with a CT scan is better than a renal scintigraphy or an ultrasound. Thank you.
Ajay?
No, sir. Both the speakers were very lucid and clear on their thoughts. They have answered almost every question on trauma.
Thank you so much.
Moving forward, next I would like to call upon our next moderators, Dr. Gajanan Ambegaonkar sir, Dr. Prashant Sonartikar sir, Dr. Kavita Makasare ma'am. I would like to call upon stage Dr. Mishri Kotkar sir to present on imaging in acute scrotum.
Good afternoon, everybody. First of all, I congratulate Ajay Oslawal and Anindya Kulkarni for conceptualizing this CME, and it was well supported by our radiology team. So thank you very much, and thank you very much for giving me this opportunity to be present here in front of you. So scrotum is a very important organ, and acute scrotal pain is very much common, and that is an emergency most of the time. And the most important thing is differentiating it, whether the trauma is the pain is because of the scrotum or something else. Sometimes even abdominal pain which radiates to the scrotum, that one has to evaluate. So any examination, if patient is sent for a scrotum, should be evaluated for abdominal ultrasound first, and then should come down. So what are the common acute emergencies that we come across? The first and most common is torsion, and torsion has to be differentiated from infection. So that will define the management. Next common are the trauma, tumors, and some less common are hernia, hydrocele, and varicocele. So torsion. So torsions can be intravaginal or extravaginal. The intravaginal torsions, which are more common in young adults, and they are common because due to the bell clapper deformity of the testis. Extravaginal, which is supravaginal also known as, and it is common in children because it is at the level of the external lingual ring. So why this bell clapper deformity? Normally the tunica vaginalis has covering up to the base of the scrotum only, the testis. It covers the testis. But when the tunica vaginalis covers up to the spermatic cord, then it will lead to the bell clapper deformity. So the testis will be floating and rotating. So that can cause rotation. So on ultrasound or color Doppler, so the twisting of the spermatic cord is the most important sign. It can be 180 degrees, 360 or 720 degrees. So 180 degrees can detorse. But 360 or more than that, it will be difficult to detorse, and then patient needs surgery. So the first and foremost thing will be incomplete torsion, that there will be some blood flow will be there. It can be obliteration of the venous flow first, or sometimes afterwards the arterial flow is also obliterated. Initially there will be increased RI, and you can say to and fro flow, and in complete torsion there will be absent blood flow. Torsion detorsion phenomenon, in which the patient may have acute pain which gets relieved of its own, but then it should be evaluated to look for the cause of the torsion. Most of the time it will be bell clapper deformity, and it may warrant for a fixation because it may lead to torsion in future. So in early phase, you will see homogeneous enlargement of the testis, which becomes heterogeneous within 12 to 24 hours and becomes necrotic in after 24 hours. You will get reactive hydrocele, thickening of the scrotal skin, hyperemia of the scrotal wall, but not in the testicle. So that is also important aspect, and one should not miss it from the intratesticular flow. And the most important thing will be distinguishing it from the infection, because that will differentiate between the management. Within the 6 hours, if it is managed, so then you can salvage the testis. More than 6 to 12 hours, there are chances, 50% chances that you can salvage the testicle. But after 12 to 24 hours, it will be difficult. So the most important thing is the patient who should be good enough and immediately go to a good doctor, and the good doctor should send to a good radiologist. Everyone here is good. That is 100% sure. So that will save the patient's life. Now second comes is the infection. The most common is the epididymitis or epididymo-orchitis or only orchitis. So epididymal tail infection is most common. In that case, the head body and the tail of the epididymis will be enlarged, and it will show increased vascularity. And you can always compare it with the other testicle. There can be associated reactionary hydrocele. And the Doppler velocities, epididymal PSV will be greater than 15 centimeters per second. Normally it is around 6 to 14 millimeters per second. But sometimes in cases of infection, you get dilated blood flow and increased blood supply. But in subsequent cases, if there is a long time infection, so orchitis can lead to some necrosis, and this is the case of where you can see there is a necrotic area, and differentiating it from the tumor is also very important, because similar pictures can occur in the cases of tumors also, but there will be reactionary intralesional vascularity will be there in the tumor, and in cases of infarction or necrosis, you will see the rest of the testis which shows increased vascularity, and the necrotic area will not show vascularity. Then again differentiating between the epididymal cyst and spermatocele. In spermatocele, definitely you can see a small internal echoes which are common in spermatozoa, and most of the times the epididymal cyst, they are anechoic, that is clear fluid will be there. Otherwise differentiating between the spermatocele and epididymal cyst are difficult. Now testicular abscess is the modality of choice is the ultrasound. There will be focal region of altered echogenicity, complex mixed solid cystic structures will be seen, which will be isoechoic to the rest of the testis, and the focal region of altered vascularity will be seen. There can be associated epididymitis and reactive hydrocele, and in this hydrocele you will be usually septated hydrocele will be there, and associated there will be thickening of the scrotal wall. This can lead to a scrotal wall abscess. Here you can see there is a air foci in the scrotal wall. Then testis is seen here normal, and this you can see the tract which is showing this infection and gram-negative foci. Differentiating it from the Fournier's gangrene, which is a very dangerous condition, one has, because it involves the adjacent suprapal necrotizing fasciculitis, so that is a very serious condition, so that has to be treated properly. Then coming to hydrocele and patent process vaginalis. So sometimes even a small child may come to your clinic because patient present with a sudden swelling. When he was in the night he was normal, and in the next day morning or after cycling for a day he comes with a scrotal swelling, and then it has to be differentiated from the trauma, or because whether it is because of trauma, torsion is there or not. So for that ultrasound will be definitely helpful. So here you can see a fluid which is communicating with the peritoneal cavity, which comes down into the peritoneal scrotal sac. So that has to be differentiated from the acute torsion. Then along with the fluid, sometimes you can see the momentum or the bowel loops also. That will also can cause swelling, acute swelling in the scrotal region. So in this case, you can see this bowel herniating, bowel and omentum herniating into the scrotal sac along the up to the scrotal head, testicular head. Now next is the testicle tumors. Intratesticular tumors, they are mostly malignant ones. Extratesticular are most of them are benign. Young males which are 20 to 30 years are age more involved. So the patient will be presenting with lumps, swelling and pain. So in first decade, yolk sac tumor or teratomas are more common. In second decade, choriocarcinoma. In third decade, embryonal cell carcinoma, seminoma, lymphoma in later age. And the risk factors are cryptorchism. So one of the most common cause is cryptorchism. Another cause is Klinefelter syndrome. If there is any family history, radiation history, microlithiasis, infections. I will not go into the details about the theoretical part. So most common is seminoma, and then next common is one is teratomas and non-seminomatous tumors, and also lymphomas. So these are non-seminomatous tumors. So here you can see calcifications, and peripheral vascularity is most important diagnostic tool in these tumors. So always look for the intraabdominal extension if you are suspecting tumor, like a para-aortic nodes in this case. And then non-germ cell tumors like Sertoli cell, they are hormonally active, they are more benign, they become malignant after a particular period. So this is a case of lymphoma, which is a adult age, and you can see a heteroechoic enlargement of the testicle, particularly involving the lower end of the testicle. In this case, you have to look for the extra testicular extension, like liver spleen enlargement, para-aortic nodes. Now the testicular fracture. This trauma is second. Usually you have to look for the testicular fracture, dislocation, which trauma can lead to torsion, then intratesticular hematoma or pseudoaneurysm. So most important thing is invasion of the or rupture of the tunica albuginea layer. So commonest finding will be hematocele. There will be disruption of the tunica albuginea and loss of continuity, crinking or retraction will be seen. Sometimes you may get the extrusion of the seminiferous tubules, and testicular ischemia or infarction can be complications. This is a case of testicular fracture, where you can see a small collection in the testicle and there is a surrounding heteroechoic area in the surround testicle. And the vascularity is still preserved, but you can see septated collection in the scrotal sac also. So take-home message will be Doppler ultrasound is the modality of choice in all acute scrotal pain. Early diagnosis is key in treatment because that will help and salvage the testis. Communication between the urologist and radiologist really helps, and documentation for medical legal purpose is the most important. I acknowledge this presentation to Shanti Imaging Center Imaging cases. Anirudh Kulkarni, my friend, he has offered me many videos, MGM Medical College images, and some articles from the Google for this presentation. Thank you very much.
Thank you so much, sir. Now I would like to call Dr. Altaf Sheikh, sir, for urology opinion on this topic.
Good afternoon, everyone. I'll be briefing up on the acute scrotum. Most of the points have been covered by Mr. Kotkar sir. So acute scrotum is an emergency, and this consists of constellation of new onset of pain, swelling, and tenderness of intrascrotal contents. And it is analogous to the patients present with acute abdomen, because so many medical conditions can cause present with the acute scrotum. So in the differential diagnosis, we need to have knowledge about the potential conditions causing acute scrotum. Ischemic events in the form of torsion of the testis, that is also known as torsion of spermatic cord, torsion of appendices of testis and epididymis, testicular infarction due to the compression of massive hydrocele or hernia, and testicular infarction in case of the vascular events. There can be a traumatic event, penetrating or blunt. Penetrating are more devastating. They cause more damage and more vascular injuries. Trauma can cause a rupture, intratesticular hematomas, testicular contusions and hematocele. Infections, they are the most common causes of acute scrotum. Infections can be of epididymis, testes or both. They can progress to abscess formation. There can be necrotizing fasciitis of the scrotal scene. This is known as a Fournier's gangrene. Then systemic vasculitis, that is henoch-Schönlein purpura, that is seen in pediatric age group. There can be fat necrosis of the scrotal wall. Strangulated hernias, and with or without testicular ischemia, as in the morning session Aniruddha sir told that strangulated hernia causing a testicular torsion. And there can be chronic pathologies like hydrocele and spermatocele. As such, they will not cause acute scrotum, but when they are complicated, the complications in the form of rupture or hemorrhage or secondary infections, they can present with the acute scrotum. And the varicocele, if they are getting thrombosed. Even some testicular tumors, they can undergo hemorrhage or infarction presenting as a acute scrotum. So, being a clinicians or urologist, we thoroughly depend on acute history taking, because so many points from the history we can diagnose the things. What is the onset of the pain? When it is a sudden acute onset associated with the vomiting, it is a more typical of torsion. And in infectious etiology, the pain is progressive gradual onset, generally more than 24 hours. And then during the onset of the pain, whether associated with the physical activity, sexual activity, trauma, associated with lower tracts obstructive symptoms, whether prior endoscopic intervention done, it has a 7-point with a 2 points given to testicular swelling, high riding testes and hard testes, absence of ipsilateral cremasteric reflex and nausea vomiting. So it has a positive predictive value of 90% when the score is 5, and it's almost 60. Clinically, you can diagnose the torsion testis when you have 6-point score. Then in infectious etiology, we believe when lifting the testis elevates the pain in case of infectious etiology, while in torsion it aggravates. Then the blue dot sign, as in case of torsion of appendices of epididymis, or it can ecchymotic and seen on the upper part of hemiscrotum as a blue dot sign. There can be crepitus in Fournier's gangrene, or acute scrotum can be part of systemic diseases like hypoalbuminemia, portal hypertension, renal insufficiencies and lymphadenopathies. Management part, after sending the routine investigations, urine cultures, we start with a broader spectrum of antibiotics and analgesics and all the conservative management, and we ask for the radiological imaging. And what we expect from the from imaging is we should be able to have a supportive to our clinical findings, accurate diagnosis, allowing us a proper triage of the patients, because we need to triage the patient whether we want to conservatively manage, medical or surgical management, and differentiate between the intratesticular, extratesticular pathology. In case of trauma, determine the extent of trauma, assess the parenchymal perfusion and viable testes, and diagnose the complications such as infarction, abscess formation, and in follow-up cases, it's very important whether there is a resolution of the inflammatory lesions. To be mentioned, we are more concerned about the surgical emergencies. It's worth mentioning here the testicular torsion, because it is said that time is a testicle, because the full torsion 720-degree twist is required to completely obstruct the flow, which causes an ischemia and necrosis of the testis. The degree of the twist can be variable in each clinical scenario, causing the partial torsion. The salvage, why the time is important, because onset of the pain, if the intervention is done less than 6 hours, that we can salvage the testes in up to 100% of the cases. As the time increases, the salvageability rate decreases, and more than 24 hours, almost they are dead testes, causing septicemia and gangrene. If both the testes are gone, patient may be infertile. This is a look on exploration. It is twisted. We manually detors in open book manner. We check for the viability. We in the warm gauze, so when it is viable, the perfusion starts. Then we ipsilaterally we fix it. When they are necrosed and non-viable, we remove it. As bell clapper anomaly is a bilateral, the opposite normal testis should be fixed. So summary is consider the wide spectrum of disease and differential diagnosis. It's a very time sensitive condition because it can have a devastating long term consequences. A high value is placed on the history and physical examination, and ultrasound is very important. It helps in the diagnosing of the most of the acute scrotal pathologies. Thank you.
Thank you so much, sir. I would like to ask our mentors and delegates to have a brief discussion on this topic.
Detorsion we can specify whether when the test has been. Yeah. Ultrasound guided not done. Not in my knowledge.
Because it has now come into the interventional radiology.
Yes.
So on table it is difficult to do the DF.
Yes.
Most of the time it goes for the artery and fixation on the other side.
Yes.
So radiologically you can try it there.
That the pain is so much, so it will be difficult for a radiologist to do it.
No, not radiologist. You accompany the urologist, and when they detors it, you have to do every half an hour the ultrasound again.
Sir, previously they used to do the manual detorsion in open book manner because most of the torsions were medial to the septum, but the success was only up to 70% of the cases.
On table
till you can buy a time to send the patient to the tertiary care center where it can be fixed.
Yes.
So it's a manual. It is just a time buying procedure. It's not a definitive treatment.
On table, do you really need ultrasound?
No, not on table. I am asking before the sending patient to the or before exploration, because on exploration, even if you open detorsion has been tried, most of the time it is orchiectomy, 90%, and it is difficult to monitor the patient if you detors it in the post-operative period. But if in ultrasound it is conservative, non-operative procedure, if you can succeed, and if every half an hour you do the ultrasound, Doppler ultrasound, you can manage it, you can intervene at any time.
And
Ideally, sir, it should be done. It should be done. Yeah, because intraprocedural ultrasound should be done to confirm
it. Would probably help to more.
Yes, sir.
More reliable probably.
Yes.
Rather than
yes, sir, definitely.
Objective or subjective.
Know that the testis is gangrenous. Can you leave it alone, or do you have to do
No, sir. Orchiectomy is mandatory. We cannot leave the dead necrotic tissue in the body, but it leads to septicemia.
Even it can affect the other testes.
Because sir, it is most of the time it's a wet gangrene. This is a venous condition which is followed later by the testicular. The initial phase is a venous congestion in twisting of the cord. So we cannot leave the gangrenous tissue.
No, that is true theoretically. Prepared immediately for it, and quite often leads to
what is the opinion about the torsion-detorsion phenomenon? Whether that needs to a surgical intervention or not?
Yes, sir. It definitely requires surgical intervention. Testes need to be fixed. Because testes to undergo damage.
Thank you.
Yes, thank you.
Thank you so much, sir, for such a valuable discussion. Now